Dr. Sarah Nowicki Gamadia. I'm an emergency physician. It's my husband, Dr. Kev Gamadia. He's a neurosurgeon. We both work at St. Francis here in town. We don't have any like formal presentation that we're gonna make you sit through, but I figured what we would do, and I'll let him go first because he has another meeting he has to go to, is just kind of tell you about what we do in our field and what the training education looked like in terms of getting there, what every day looks like. And then if you have any specific questions about like, you know, the types of patients we see or the cases or whatever, we'll let you ask all those. But I'll let him go first because he'll have to leave.
So I'm Kev Gamadia. I'm a neurosurgeon. A neurosurgeon is someone who deals with the surgical aspects of neurologic disorders or disorders of the nerves, if you will. So to get here to where I am, essentially, you know, the journey starts typically after high school. You're in college. You would do 4 years of undergrad, and you know, I'm assuming all of you are interested in medicine. Is that my okay? Great, that's awesome. So I'm sure you guys are. What grades are you in? Are you like in 9th, 10th grade, 11th grade, 12th grade? So you guys are in the process of applying to college at this stage, I take it, and looking at strong pre-med schools is probably my understanding. All right, so great. So when you get to college, you're going to be taking courses that are pre-med concentration. Most of you, I think, would be. Are you most of you applying for like a science, like a bachelor's of science degree, or are you guys taking different paths as well? Are you interested in taking a different path, not just a bachelor's in science? Like what are you applying for? Do you not really? You don't know? Okay. Yeah. What's that?
I'm going for like a master's in nursing and stuff.
That's great. That's awesome. Right. So there are other paths you can take. It's a little longer. For example, you can go into bachelor's of business and then also have a pre-med track. So you get best of both worlds that way. But the majority, you know, ourselves included, went through the bachelor's of science. And my concentration was in biology, and then I had a minor in forensics. So you'll be taking those classes, and they're weeder classes. They're difficult because they're designed to kind of weed out a lot of in the initial class that starts as freshmen to get through to the end to get your pre-med credits. And then during your pre-med and during your college time, you'll be applying for med schools. You'll be taking the MCATs, which are the entrance exams for medical school. That's your big bottleneck, essentially. And then once you get to med school, which I'm sure all of you will work hard. If you're still, and many people in college, they get there and they're like, you know what, this isn't for me. And that's totally fine. There are many other things that you could do as well. Once you're in med school, essentially what happens is you have 4 years of med school. So you after your 4 years of undergrad, and you're in medical school for another 4 years. And in med school, essentially you start thinking about, or you may already have an idea as to what you want to do, what type of specialty you want to get into. Some folks have an idea very early, and that's formed by experiences they may have had, reasons why they got into medical school. For example, I got interested in neurosurgery before I got into medical school because I was very interested in spinal cord injuries and trauma at the time. When I was a kid, I foolishly raced motorcycles. I don't recommend anyone to do that, but we saw quite. I had a few kids who got injured and then they were paralyzed from the waist down, and we didn't have anything to offer. Medicine still today, really. I mean, that will change very rapidly. I think is we have to give them wheelchairs, and we still do, and we can't get them to walk again, which is that was my big motivation of going into neurosurgery. So some people have that. Most folks don't. They get into medical school. They go through the classes. You'll have shadow rotations, and then you'll know what exactly you want to do, and then you'll start thinking into going into those tracks. In medical school, you'll sit for your MLEs, which are your standardized exams and tests, which is what a large portion of those grades that you get will be used towards getting into residencies, particularly if you take competitive residencies. Like, if I had to do it again, I'd probably be a dermatologist. But whatever you choose, that's part of what is a standardized kind of grading system where how residents are chosen. That's not the only thing by any means. It's a whole different process when you get to that stage where you go through interviews with the residencies you get into or you're trying to get into, and they look at a whole plethora of things. Most importantly, would you be a fit with the other residents and things like that at that point. So residency is your postgraduate training in medicine, where you actually really learn to become a doctor. The medical school gives you building blocks and information, knowledge of the human body and how it functions and what happens when it goes in a state of normal functioning to disease, and gives you a building block for that. But you really learn how to be a doctor in the residency that you choose to go into. And then those residencies can go from anywhere from 3 years, like in family practice or internal medicine, 4 years, kind of like emergency medicine, like Dr. Gamadia here is, and then up to 7 years for neurosurgery, which is what I did. So that's about one of the longest residencies. And after that, you can still further specialize. It's called fellowship, if you still want to become even more subspecialized in the profession you're in. And kind of that's where it is. And then after you get through all that is when your life really starts. And you really start learning how to be a doctor. Because all that's giving you kind of building blocks, and then you really start practicing your own medicine. What I do really quickly is, so I will deal with things like, we talked about spinal cord injury, head traumas, things like that. Then neurosurgeons also deal with things like brain tumors, the diseases of the blood vessels of the brain, the spinal cord tumors, and then more commonly the degenerative things or arthritis, when arthritis develops in the spine and starts compressing nerves. We do surgeries to take the pressure, relieve the pressure off those nerves so patients don't have pain, and things like difficulty walking. I can't walk halfway around the grocery store without my legs getting heavy and tired, and I have to sit down. Or I have severe numbness and tingling in my arms because they have, from arthritis, they have pressure on the spinal cord and the nerve roots. Those are the common things we do as neurosurgeons. In the adult world, you can specialize. Neurosurgery has a lot of specializations too, where some people will choose to become pediatric neurosurgeons and they take care of children, neurological diseases that require surgery with children. Some people specialize in just tumor work, and each specialty has something like that. So that's kind of my little journey in a little nutshell. Do you have any questions for me about neurosurgery or medicine in general, or am I doing the right thing?
What did you do? Undergrad, med school?
Sure. So I did my undergrad at Baylor in Texas. I did my med school here in Missouri, up at Kirksville. And then I did my residency out in Ohio, in Dayton, at Ohio University. So, sure.
You said you had to do it over.
I'm being flippant. It's a joke. Yeah.
Tell me what that.
Well, it's just because a neurosurgeon's life is a very exhausting one. It's long hours of work, lots and lots of call that takes you away from family obligations and life events like children's milestones and things like that. Important family events, holidays, Christmas, because of the amount of call we're on. There's not a whole lot of us. There's only, I think worldwide, there's about 7,000 neurosurgeons. We have about 4,500 of them in the United States, or 4,000 in the United States. So there's not a whole lot of us to go around. It's a very, 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 very small specialty.
So what type of thing would you be called in?
Oh, anything from an injury, for example, somebody falls, and especially the elderly, they fall and they develop bleeding in the brain, or bleeding between the coverings of the brain and the brain itself. It's called a subdural hematoma. Sometimes that will require emergency surgery, that I'd have to go in and do what's called a craniotomy or get into their head.
You mean the one that cracks the skull and that to relieve the pressure?
Yes. Yes.
So they have to wait in the ER then for you to get there to do that.
So I wouldn't be in the ER, go to the operating room, yes. But yes, the ER would be calling me. But that's one thing. Then there are other things, spinal cord, spinal injuries as well, spine fractures. They would be calling me for things like somebody who may end up getting like a sudden infection in the spine, or anything that essentially requires surgical intervention. Any type of neurologic problem that requires a surgeon's intervention is what they would call me for, essentially.
How much time do we have with you?
I have to leave at 4, so we have.
Take it from me, Tony. I want you to be able to ask the questions you want to ask.
Yeah.
And that you can ask them right now, but if you're too shy, I want you to go to this Bitly link. I'm going to put that on the board. It's bit.ly/clubmedpad. C, N, and P are all capital.
Yeah.
What's like a typical day look like for you?
Today, or is in residency?
Like now.
So today it's a lot more structured. It depends on the day. So I am in surgery on a typical work week. I'm in surgery either 2 or 3 days in the week, and the rest of the days I'm in clinic. So some days I'm in clinic 3 days a week. Some days I'm in clinic twice a week seeing patients and determining whether they need surgery or not and booking them for surgery. And then the other days I'm operating on those patients, and those are mostly what we call elective patients, or patients that we see in the clinic. They're not an emergency. That's the other part. There are 2 parts. The elective is it's much more controlled. It's something that it doesn't have to go immediately, like we talked about with things that I would get called from the emergency department for example. That's the other part. That's the part on call, which there are a lot of specialties. There are a lot of physicians where after they finish their certain amount of time that they're on call or a shift, they get to go home. They don't get called again, or they're off. It's called post-call. They don't have to go back. Neurosurgeons, like I said, we're very few. We don't have that luxury. We continue to work through call, and so many times there's very little sleep. We go back to work, even though we haven't slept. Maybe we sleep 2-3 hours and we go back to work. So it all depends on what specialty you're in. So that's kind of my work week today.
So like on an OR day, like when will you start? How long will you be in the OR?
Sure. So I would start typically, my first surgery is always at 7 a.m. So I'll be there in the hospital by about 6:30. And then depending on the surgeries I do, they can be anywhere from 8 minutes to 2.5 hours on average. And I'll do anywhere from 2 to 5 cases a day, 6 cases sometimes a day at this stage. Yes?
How much time would you say you spend in the surgery room compared to time with your family or by yourself?
So at this stage in my career, it's not horrible. So I'm home anywhere from 3 p.m. to 5 o'clock, 5:30. So, and then I have some time with my wife and my children. Our children are young. We had to wait till both of us finished all our training to have our children. So that's part of the sacrifice of being doctors. Your life starts a lot later than your peers. Most of your peers will have started and have jobs and have a steady income much, much earlier and younger than you would. So at this stage, yes, it's not the best. I agree. I can't make many times I can't make it to regular games or travel events that, for example, my daughter rides horses and they have events, and sometimes I'm on call. I can't make it. So it just depends. But it's much better. When I first started, when we were residents, and then early on in my career, I hardly saw my wife and my children.
Yeah, when we were in residency, I was on nights for 2 years straight. and he was on call for 7 years straight, pretty much. And we would pass each other on the freeway and wave to each other on the freeway. Or we'd have breakfast in the doctor's lounge, and that was our date because that was the only time we saw each other all week.
You got a lot of questions up there on the board there, too.
Oh, I'm sorry. Let me see. No, I got it. Just need to step back a little bit. What skills are most will you ever say no to doing?
I have a lot of questions for you.
Okay. Where do I start? Jeez. Did you end in a lot of student debt? That's a great question. That's actually one of the most important questions today. And whoever brought that up, that's a very good question. I was fortunate that I didn't have any student debt. I had scholarships, and then my parents helped me. If we both had student debts, we would still be paying them off. Actually, we still are paying off some of the debts that we are in. So on average, depending on the residency you go, or depending on the type of med school you choose, and what the med school is going to cost you, what your undergrad's going to cost you, what do you say, Sarah, about $250,000?
Yeah, right now it's about $300,000 for people that by the time they finish residency.
And you have to keep that in mind. You have to pay that back with interest. That's $300,000 in interest that you've accrued, that you're going to pay back over, I don't know, 20 years after you're done.
Yeah, so it's, I mean, you definitely have to do some math before you make that decision, because it is, like you said, you're starting life later, you're starting your earning potential later. So you're not saving, you're not investing in retirement, you're not investing in the stock market, you're doing nothing to grow your wealth that you're going to have later on in life. And now you've got debt that you also have to pay off. And so these are definitely things you have to consider. And it's one of the reasons why you hear people complain that there's not enough physicians that go into primary care. People have great intentions, and a lot of people start out going into primary with the thought they're going to go into primary care, and then they start doing the math, and they're like, wait a minute, I've got all this debt, and right now they're only paying on average this, 200, maybe, I don't know, 250,000, and they I don't think it's that much, and they're like, well, how the heck am I ever going to pay off my debt or do any of the things I want to do in life with that as my income? But there's also, there are certain government programs. You can go into the military; they'll pay for it. There's certain
rural health places
structures
like us in Cape Girardeau.
If you work in certain settings, they will pay off your loans after 10 years. A lot of hospitals are so desperate for doctors that they'll pay off your loans as long as you sign a contract saying you'll work there for so many years. So there are workarounds, but there's never any guarantee. So when you take on that debt, it shouldn't be without pause.
Right, and the income potential or the earnings of a physician have steadily declined year after year after year, and that's part of the problem. Is the education costs have gone skyrocketing, but what you make when you come out is not nearly what, let's say, somebody made 10 years ago or 15 years ago or even 20, things like that. So that's a huge consideration, a factor to really take into. I mean, it's a great profession. It's a very rewarding profession, but this is actually, if anything, and I'm glad that's the very first question, because I was just talking to my wife on the way here. I said, that's the most important question that you have to ask yourself today is, am I ready to take on that? Because, it's not a huge consideration right now in high school, but getting through life, that will really, that's a lifelong commitment you've taken on if you choose to go down that path.
And don't get us wrong, it still pays well. I mean, compared to the average American, it's still a very good paying job. But if you are going into it with the intention of being a rich doctor, it's not the way to go, because there's so many other ways that you can make money way easier than becoming a doctor.
Learn to work with artificial intelligence and get on the curve for that. If that's what you want to do, make a lot of money, and that's what you want to do at this stage. Okay. What skills are most crucial for a successful neurosurgeon? Oh my God. Willpower and perseverance. to be able to do it. It's very long, very difficult, physically, mentally, emotionally. It's a very long and hard road. So I think more than anything else, the skills, yes, you need to be very good with your hands and very facile. You need to be able to think. You need to be able to work under a lot of stress and duress. The things we do are very delicate and very high stakes, because you can hurt somebody really badly if you make one slip up in the surgeries we do, because we're working on the most critical part of the human body, which is the nerves. They're also the most fragile, and they don't repair well. They don't heal well. So that's part of the challenge and the secret of, the things that are the most vital to us are also the most delicate. So I'd say that would be the answer at this stage of what I would give. What is the most complex surgery you have completed? Oh my God. There's several. Large brain tumors in the back part of the posterior fossa of the brain are very complicated. Sometimes aneurysm surgeries or surgeries of the blood vessels of the brain, some of those have been complicated. One of the ones that stick out to me, I remember when I was just out of residency and training, and I just started as a young surgeon, and I had a patient. We practiced in Fort Worth before we came here, so we were in Texas. And this young girl who was a master's in accounting student at Baylor actually was referred up to me she had a big spinal cord tumor in the upper back, and it was affecting her. And that was a surgery that was very delicate, very long, and it was successful. She did really well, had no complications, and she's graduated. She's a very successful accountant in life today. Hi. So yeah, it's very rewarding too. Who do you work around? Do you work around any CRNAs since they deal with? Yes, we work around with a lot of CRNAs actually. So you all know what a CRNA is? Okay. So the nurse anesthetists, you go into nursing, and then from there, there's a program they have to go into. They need to be an ICU nurse for 2 years, and then after that, they can go into this program called nurse anesthetists, and they help. They fill the need for not having enough anesthesiologists. So the physicians, they're supervised by one anesthesiologist doctor will supervise 3, maybe 4 nurse anesthetists that are running in the operating room. So they will be present. The doctor will be present at the critical stages, which is putting the patient to sleep, getting the breathing tube down, and then hooking the patient up to the monitoring system. I mean, the heart-lung machine, if you will, or the respirator. And they will then basically run the anesthesia at that point. So that's what they do. Yes, and we work around CRNAs all the time. Yes, and it's actually it's a very good line if you go from nursing. If you want to do beyond just normal being an RN, there's other tracks. You can become a nurse practitioner, which is essentially, that's a different topic entirely, but something that you may want to look at to be, as a nurse practitioner, you're basically functioning like a physician under supervision of a physician. At least in Missouri, you have to be. Other states, they're independent. And a lot of that is as a result of the acute shortage of physicians. There's not enough doctors to manage the sick populations of our country as we age. So, how many exact years did it take to become a neurosurgeon with and without residency? Well, you cannot be a neurosurgeon without residency. So you have to go to, that's your postgraduate part. We talked about it. So 4 years undergrad, 4 years of medical school, 7 years of neurosurgical residency. And then if you do fellowships, most fellowships are 1 year. If you choose to become a pediatric neurosurgeon, it's 2. So 9 years. So that's 8 plus another 7 to 9 years. What's the longest time a surgery has taken to perform? I have been the longest surgery I've ever been participated in was 23 and a half hours.
I started calling the hospital. I was like, is he still there? He's not answering his phone. Where is this guy? And they're like, oh, they're still in the OR.
It was a very large and complex brain tumor in a 4-year-old girl. So we had to do multiple approaches. Did it great. What else? What advancements and treatments have you seen over your education and career? I think the push towards more minimally invasive surgery, smaller incisions, working through smaller incisions, using instrumentation, different approaches and techniques to cause less injury and damage to the normal tissues of the body while doing surgery. Other advancements are coming. We saw a lot of advancements in endovascular. Again, the same thing so an aneurysm is a weakness in a blood vessel in the brain, and many times we're born with it. Sometimes it occurs as a result of doing bad things like smoking for many, many years, things like that, having uncontrolled high blood pressure, diabetes, lifestyle choices, for example, drugs. And as that wall weakens, it can break or rupture. And the problem there is blood is an extreme irritant to the tissues of the brain, to the nerves, the neurons. When it comes out of the places where it's supposed to run, like the blood vessels and the blood channels that exist in our brain, and it contacts the brain, it instantly kills those cells. So an aneurysmal rupture is a very serious problem. And traditionally, it was every one of them had to be treated with surgery. It means opening the head with a craniotomy, and then going and putting a clip onto that weakness of the blood vessel to stop that bleeding from that defect, and then that was it. But through my training and early onset training, a lot of techniques were developed where actually the majority of these are now repaired just by going through a vein in our groin, essentially, and through the blood vessels, fishing instruments through the blood vessels of the body, and then directly into the problematic vessel, and then actually sealing that defect from within. So it's a lot less morbidity. Morbidity means damage to the body, essentially. So it's a lot less morbid for a human when we do it through that procedure versus the traditional open craniotomies. That is another one.
What is it about blood that would kill a neuron being in contact with it? Is it like concentrations of things?
It's the change in the milieu of that nerve. So our central nervous system, which is our brain and spinal cord, essentially, and then the nerves that initially exit out of the spinal cord. They live in their nice, happy medium. We have something called the blood-brain barrier, okay? And that's designed, it's very elegant. It's designed to keep those structures insulated from things like infections, changes in body chemistry that may occur from increases of blood sugar or other catabolites, other elements like sodium, potassium, things like that. Blood does not cross that. It keeps it protected. When blood crosses it, the neurons are not in their normal happy medium anymore, and they get destroyed. So, all right, what else? Will you ever say no to doing a certain surgery if you do not have a good feeling about it, or if you believe it is too complex? Exceedingly so now, as I'm older and wiser, and I've done this for 15 years plus in myself, and then much, much longer than that in training. Yes, all the time. You have to know your limitations. When we come out of residency and you're trained in a good program, which I'm sure and hope all of you will be, you've seen a lot, you've done a lot, because you've been in apex, large training hospitals that have huge amount of resources to support what you do after you're done. Because, my part in the care of a patient is about that big. There's a huge amount of other things that go into it: nursing care around the clock, other critical care physicians afterwards, rehab facilities, And with the shrinking healthcare budgets, we are a lot of the higher tertiary care things like spinal cord injury rehab unit, for example. Those don't exist in towns our size. So you don't realize that when you come out, because you feel like, I've spent all this time training and I'm ready, I'm comfortable, I'm confident. And yes, I have done a lot of surgeries. Now, when we were in Fort Worth, it was different because we accepted everything. We had all the facilities. But when I came here, and I started doing the same type of cases I was used to doing in a bigger city, I quickly realized that it's not the best thing for the patient. Yes, I can do the surgery. That doesn't mean I have the resources that I need, the tools that I need in my operating room, or the care that's required after I finish the surgery. So yes, we routinely triage and send patients to a larger facility, an academic facility. Like, for example, for us, 99% of the time it would be St. Louis is where they would go. Do you need to learn neurosciences to go into the field of neurosurgery? So that's it's a very specific question. Neurosciences are they're broken down into neurobiology, neuropsychology, and the answer to that is no, you don't. You do get a certain core amount of neurosciences when you go through your pre-med core. You're going to have part of that in your biology curriculum. You can certainly take neuroscience subjects. You could take neuropsychology, for example, would be one of them as an undergraduate class, depending on which university you go to, what college you go to, and what they have available to you. But the answer is no, you don't have to necessarily go into neurosciences. A lot of us do because we're just naturally very attuned and are the ones at least who know that that's what I want to do in college. I did, because I gave you the example of why I wanted to be a neurosurgeon, but that doesn't mean everybody else does. That most of them, many of them, get into that after when they're in medical school at that point. Awesome, wow. Well, thank you for your time and attention. Do you have any questions for me? Well, all the very best in your careers and lives. We need good doctors. We really, really do.
Someone needs to take care of us when we're old. All right, so I'm Sarah Nowicki Gamadia. If you ever run into me at the hospital, I just go by Sarah Nowicki. And as you ladies go on if you go on to medical training, that'll be something that may or may not come up for you. So when you go through school, all of your degrees and everything are probably going to be in your maiden name unless you're married beforehand. And so we met in medical school, and I had told him, I was like, all right, we either need to get married, or all my degrees are gonna be in my name. And he's waited and waited and waited and waited, and so forever I was just Sarah Nowicki. And because there's a lot of work that goes into changing your degrees and all your board scores and everything to correspond with your name. So yeah, the poor guy, he didn't get Gamadia added to my name until we were married for like 10 years. But I legally have an alias, and so I practice under one name. But for civil reasons, I can go by either name. But if you ever run into me or whatever, it'll be Dr. Nowicki. If anybody ever says Dr. Gamadia, they're gonna think it's that guy. They don't know. I'm not Dr. Gamadia. But so I am an emergency physician. So I went to my undergrad was at Michigan State. And then I was a human biology major, and then we both went to Kirksville, and so I was there. I did my training there for your first 2 years are academic, your second 2 years are in the hospital. So we were in Kirksville for 2 years, and then we were kind of all over for the next 2 years. And then for residency, just like my husband, it was through Ohio University in Dayton, Ohio. And I did emergency medicine, which at the time was a 3-year residency. It is now a 4-year residency. And emergency medicine to me is the best specialty, especially if you have a little bit of ADHD and you like to constantly be moving, you like something different all the time. It would drive me bonkers if I saw back pain all day long and saw the same patients, the same complaints, the same surgeries, the same whatever. I would go crazy. So in the emergency department, we work shift work, which, depending on where you work, might be an 8-hour shift, 10-hour shift, 12-hour shift. Some of the rural places will do 24-hour shifts, but we don't take call. And because we work harder while we're there, we work fewer hours in general, like because we're not taking call. Our full time for an emergency physician is 30 hours a week. And then when we're off, we're off. And so that's always really nice. A typical day, we will see, it just depends on how many people show up that day and how big the department is that you work in. On average, I'll usually see 18 to 24 patients a day. And sometimes those will be super low acuity things. Acuity meaning the severity of what their complaint is. A lot of people, especially as we have fewer and fewer physicians, it's harder and harder to get in when you have a sudden problem. And you know, there's a lot of people that don't have health insurance, whatever. Legally, an emergency department can't turn away anybody. So we see a little bit of everything, including the low acuity stuff like an earache, a cold, a flu that didn't necessarily need a hospital or hospitalization. The fun stuff that we see, and the reason why people who go into emergency medicine is that we get like the first hour and the most exciting part about every other specialty. Yeah, I'm the one that gets to diagnose the heart attacks and then call the cardiologist and say, hey, I have a heart attack, come put a stent in them. I'm the one that calls the neurosurgeon and say, hey, I have a patient that has a head bleed, but I was the one that got to see them, diagnose them, maybe put a tube in their throat because they weren't breathing on their own. Same thing with strokes. If any of you are on Facebook and follow the hospital, they just had me on there the other day because on Tuesday we had another stroke patient, but we're the ones that see the patient. We say, whoa, I think this is a stroke, and we give them a clot busting medication to hopefully break up that blood clot and relieve their stroke symptoms, which is definitely something cool. Let's see, what else? For the surgical ones, we get we get the traumas. And so they get flown in or they get brought in by ambulance. We meet them in the trauma bay, and we figure out right away, do they have a head injury? Did they puncture their lung? Do we need to put a chest tube in, which is a tube we put in between the lung and the chest wall because the lungs collapsed from the trauma. And we reset all the bones, and let's see what else. We try not to do too much with OB in the ER. we let the OBs take care of that stuff, but we do occasionally deliver babies. We get to see all kinds of cool stuff. The hard part about emergency medicine is you're seeing everybody on their worst day. I'm sorry, I don't know why that makes me choke up. You see everybody on their worst day. And in fact, just today, right before I left, I had to tell somebody who came in for weakness. The reason he's weak is because he has cancer everywhere. And, you take all that on and you take it all home. You have to, you deal with it while you're there, but then you still have to go home and make dinner and take care of your kids and do all the things. And so it is hard, but it's also, I think it's also amazingly, it's an amazing profession in the sense that there's so few professions where what you do every day actually makes a difference. Thanks. I'm a crier. And actually, my husband laughs at me. We were talking about this the other day about I had said so. He had commented that I had given one of my nurses a hug. And I said, well, of course I did. They were crying. Of course I'm going to give them a hug. And I said, I hug my patients too. I cry with my patients. I hug my patients. And so healthcare is amazing in that sense that you really do get to make a difference for people. And if you're a religious person, it's you can really feel like you're doing God's work every day. But obviously it's hard. We take a lot of trauma home. We deal with a lot. In fact, something we haven't talked about, there is greater rates of depression, greater rates of suicide, especially among female physicians. It's like the highest of any profession for females. It's and there is a lot of that being addressed now in medical schools and residencies. But so I suppose that's something also to consider if if that's ever been an issue in your life, that it could potentially, be a stressor that you may or may not, be able to bear. But yeah, so that's what I do in a nutshell. See, I laugh, I cry, I do all of it all in a day, and and then you pick up and you move on and you keep doing it. But I wouldn't do anything else. I don't even know what else I do. And in fact, we always joke that they would never allow us ER people out of there because we're all a little nutty. Do you guys? Yeah, go ahead.
Like, what made you want to do emergency medicine? Did you always know?
No, not at all. In fact, I didn't even know. I'll probably block my microphone. Whereas my husband always knew he wanted to do medicine. His parents were doctors, his grandparents were doctors. He, was interested in the spinal cord from a young age. I was not. I grew up my dad he owned a construction business. I grew up in Michigan, where everybody goes into engineering or works for Ford or whatever. So I actually went into college with a mechanical engineering major, and then got so bored sitting at a computer all the time. And every time someone would walk by, I'd be like, "Oh, hi, want to talk?" And then I went to a meeting kind of like this. There was an advert. We had all the same the engineering people had all the same prereqs as the pre-med people. And so somebody had put up a flyer for a pre-med meeting, and I was like, "Oh yeah, hey, I'll go check it out." And it turned out to be a meeting for osteopathic medicine, and I was like, now osteopathic and allopathic medicine are pretty much the same thing, but I was just blown away. I love the theory behind it. And so I switched to pre-med because I wanted to be an osteopath. And so I finished college, went to medical school. And then in medical school, you do those first 2 years in the classroom, second 2 years in the hospital doing rotations. And it was during those rotations where every single month like I said, I'd get bored by seeing the same thing. If I was on cardiology, I saw chest pain all month long. I'd be like, "Oh God, I can't see more chest pain." And so, but I also was interested in so many of the things. I'd be like, "Ooh, I want to be an ophthalmologist. I like the eyeball. Ooh, I love looking at x-rays. I want to be a radiologist. Oh, I want to be a pediatrician. I want to be an OB. I wanted to be everything a little bit." And you're not allowed to even rotate through the ER until you do all your core rotations, because they want to make sure you know a little bit about everything. And I got there and saw that we were seeing all of it. I was seeing all the specialties, and I was seeing such a variety. And then I was like, "Oh, this is where I'm supposed to be." Okay, so that's how I ended up with emergency medicine. Yeah, go ahead.
What's the worst thing you've seen from like a family member?
My own family members?
No, like from your patients.
Oh, well, probably the most common is you get really dramatic reactions for a sudden death. You'll have a patient that was brought in, probably coding, so EMS brings them in, they're doing chest compressions, all the things, and we do all the things we can try to do to bring somebody back. And when it is unexpected, especially if it's a child, and I don't just mean like a small child, I mean like the child of somebody. It's usually mom who just really does not respond well to hearing that she lost her baby, even if her baby's 50 years old. Yeah. What else you guys got? Yeah, go ahead.
How many years did you have to, how many years of school in Czech?
So it's all similar, 4 years or however long it takes you to do your undergrad. 4 years of undergrad, 4 years of medical school, and then for me, residency was 3 years. And so, let's see, by the time I was done, if I finished high school at 18, college at 22, residency at 26. No, that's not right. Residency. No, was I 4? Oh, okay. Yes, I was 4. Yeah, I was. Yeah. So yeah, I finished high school at 18, college at 22. medical school at 26, and residency at 32, or at 30. 30. Sorry, I can't do math. Yeah, no problem. Yeah, you're right. I was 4. I forgot about that. Time flies when you're having fun. Yeah. Yeah. So your residency is where you learn your specialty. So whether it's internal medicine, pediatrics, OB-GYN, general surgery, orthopedics, whatever.
So I think the only thing I want to add before I go out of here is you brought up a point between the MD and the DO teaching. Do you guys know about this at all? Have you looked into that at all? So in medicine, there's two, at least in America, there are 2 different medical school and degrees that you can go into. One's the MD, which is the traditional allopathic track, and the other is the DO track that we are. So that's the osteopathic track. Not to get into the weeds about this, there used to be a difference like
100 years ago.
80 to 100 years ago. And all that's basically just funneled down to the point, and now today to the point is that you may go to a DO or an MD school, but you're going, the federal government said you're going to do all the postgrad is the same.
You're going to the same residencies, you're taking the same tests.
Even though there were different programs, when we went through the programs, the standards were pretty much the same, but it was just a political thing. The 2 political bodies wanted their own autonomy. And then the federal government said, no, if you want CMS dollars, it's going to be the same. So by the time you become a fully fledged physician, today they're going to be the same degree. There'll be no, I mean, us, the older folks, I mean, for us, we have faced discrimination from the MD side a lot, but all that is gone. So you really don't have to worry. I would, if you can get into an MD program for some reason, but you did or you loved the DO. For example, I was waiting to hear back from some of the MD schools, but I went to Kirksville and I absolutely loved the professors and their style of teaching, and I went there for that reason more than anything else. Today, really, there's really no difference. So I mean, it's a non-starter whether you go to an MD or a DO school. Really going to the same level.
So what the difference was originally, literally hundreds of years ago, was, and I mean, we're talking before antibiotics, before sterile surgery, all that stuff. The person who started osteopathic medicine had said that he didn't like how the allopaths were treating medicine or were treating disease. He said that the reason disease exists is because our normal homeostasis, there was something out of place in it, whatever it was. And so it was because there was something wrong with our structure, whether it was our blood or our bones or whatever, that was what was creating the disease. And it does focus a lot on musculoskeletal stuff and how that can affect your health. For instance, you have bad posture. Well, maybe by the time you're 80, you can't breathe so well because your posture has limited your lung movement. So it was those sorts of things. But at this point, yeah, the training's exactly the same, the education's exactly the same. Oh, I know all the girls all of a sudden were like,
You don't want to breathe that way.
right. Yeah, go ahead.
What would you say like we should be doing to prepare ourselves for college and medical school?
Probably study skills. One of the hardest things in medical school is the pure volume of information you're expected to learn at one time. And for instance, when I was in undergrad, the way I liked to study was I would read it, and I'd highlight as I read, and then I'd write what I highlighted, and then I'd reread what I highlighted, and it would take forever. It was very effective for me, but it would take forever, and I couldn't do that in medical school. So I had to learn new ways to figure out how to retain all that information. And so yeah, your study skills for me were the big thing. What do you think?
Even before that, I mean, you have to get to medical school first. So the key is choose the right colleges, the colleges that are competitive for pre-med, of course. And then when you're there, just understand that these classes are brutal. They're designed to weed students out. Okay, so you're going to compete with your peers for grades to get through those pre-med bottlenecks. So find a good study group when you're in that pre-med with the core. Some of the places have like clubs and societies for pre-med students to sit and learn, because just like every standardized test, there is a way to learn and take it. Once you crack that code, it becomes easy.
Mm-hmm.
So I don't, educators don't want to hear that. But that's the key, is to understand how this works.
Yeah.
You're going to have classes that you have to take that you'll never use in medicine. You're going to take things like inorganic chemistry. You're going to have to take calculus. Again, you're going to have to take calculus-based physics potentially in certain places, but you're going to have physics classes. You're going to have genetics, which, yes, that does play a part in medicine. But you're going to have all this, and the exams are deliberately made very, very difficult, and the answers are not very obvious. Of course, they're multiple choice, but they're not very, very simple. Again, a lot of that just to see is, can you figure this out? Can you figure out what I'm asking you? I mean, unfortunately, there's no rhyme or reason except to just, it's like this pre-med course starts out like this, and then you'll have a bottleneck like this, and from that, only that many people will actually make it to the end at 4 years, essentially. So that's how it's designed. So that's what I would say at this stage. When you get it first, right now, you're focused on getting to the right schools, and then when you're in there, quickly find out like the groups that you can study with. Because when you try to do it by yourself, it's going to be hard. You're going to need people that who are like-minded, who are in the same together. And in some places, like I said, there's these clubs. Join those. And there's a lot of sacrifice. When you're going to be a freshman, a lot of the kids are going to be out in football games and going to parties and things like that. You're not going to be doing that. You're going to be studying.
You can do it a little.
A little.
The other thing too, and I don't.
Behind in your grades.
Granted, we went to medical school 20 years ago, but one of the other things was you needed letters of recommendation, and so to get those from your professors, you needed to have a relationship. They needed to know who they were writing a letter for, and so that means going to teachers' office hours and meeting with them so they know who you are, so that they can actually give you a letter of recommendation. They're not going to write a letter for somebody who they don't even know if you show up to class. If you're in a lecture of 300 people, they don't even know if you're there. So, yeah, no problem. Yep. Yeah.
So, about schooling, would you recommend like a junior college for like getting just a general education before you go to?
I really don't know. In general, for the general public, general education, I love that option, using that to get your basic first core, year or two of classes. I don't know how medical schools look at it. I would imagine I would think that if you were there for the first 2 years and you transferred to your 4-year university and you did great on at the second 2 years of your college education, you took all the tests, you did great, I would think it would be fine. I just don't know of anybody that took that path. And keep in mind too, there's so many great professions in healthcare. There's a huge shortage of radiology techs. They make great money. They get all the benefits. Granted, they have call because we need ultrasound overnight for the ER and everything else. So radiology techs, phlebotomists. If you love physics, there's in the radiation oncology department. There's what's his title even? Some nuclear physicist that does all the math and does all the things. And so you know, there's so many roles in healthcare that aren't necessarily the doctor, the nurse, you know, the CRNA, whatever. There's if you have an interest in healthcare and you have an interest in something else, you can definitely still mold the two. It doesn't have to be, you know, nurse or doctor or whatever else. All right, you guys good? Got any other questions? All right, you guys have a good afternoon.
Thank you for this.